Hey, happy Monday afternoon. Dr. Alan Christensen here with you for Office Hours Live. Good to connect. I'm with you all on Facebook and Instagram and YouTube Live and Twitter. We're on lots of platforms today. And the thought here is to get caught up with you and see if we can make a difference on any ongoing thyroid symptoms. So love to hear top things that are going on, where you're from, any big thyroid questions you've got. I had a couple points that I was going to mention, and I'll come to those momentarily. And then we'll cover some of your questions, some general thoughts. Detailed ones are good. We've got someone from Iceland with us, so welcome. Yeah, the more detailed, the better. I mean, really, it's easy to find, quick information that's just generalized and written down non-specifically, but it's hard to find things that are really specific for you. And with office hours, I had several good professors that I would hang out with in their office hours and learn all kinds of things that I wouldn't otherwise. So that's the idea. Let's have a good conversation. We got someone here from Illinois as well, keeping tabs on you guys on the various platforms. So I've got a couple of thoughts to share about just thyroid meds, who needs them, who can stop them, when they can be safely discontinued. There's been a lot of exciting new research about that I'll share with you guys. So yeah, and I'll mention those shortly. I'm seeing many more jumping on here. Sporadic fatal insomnia. That's interesting. Fatal insomnia. I saw this is from Iceland. That must mean something different. So fatal would mean you would die from it. And I wouldn't be hearing your question if that happened. So I'm not totally clear on that one. But more details, yeah, please put in some more details about that. Happy to talk about sleep. Here's some good questions coming up too. If I could only grow back my own thyroid. More about pre and post standardization for compounded NDT. These are perfect. I will cover a bunch of these. Many more jumping on. Welcome you guys. Office Hours Live. We're pretty much exactly at start time. And yeah, I'm with you all on Facebook, Instagram, YouTube, and Twitter. So we're on several platforms. So say hi, tell me where you're from, tell me your top health concerns or goals. And if I've got any insights that could be useful, I will certainly share those. And if you do put a question up, hang out because I'm probably going to get to it pretty quickly. And I will probably have follow-up questions for you as well. So yeah, the more we can get some depth going, the more useful this can be for you. Kim's with us. Hey, Kim, good to see you. Getting some feedback about the MRD, completing that. Yeah, we'll definitely talk about that. Good job for getting through that. Okay, so a couple slides. I want to share a couple slides with you guys real quick here. Here's one about just, people traveling. Yeah, aesthetic love. I'll talk about that. Medical legal guidelines, states and state to state. It's a patchwork and it's a mess. My apologies. It's nothing that we want or we've chosen, but I'll talk about that as well. So yeah, quick thing. Here's a couple studies that have come out recently about people who have been able to come off thyroid meds, their ability to discontinue that. And this first study, this was one in which they took a group of 291 people and they were on thyroid meds, but they hadn't had a diagnosis of hypothyroidism. So let's talk about that. So hypothyroidism. Now, we can mean this in a broad sense and talk about anyone who's not feeling well because they don't have the right amount of thyroid hormones, and that's valid. But in terms of how things are categorized in research, it just means those who had an elevated TSH plus a low T4. So both together, that's how they define hypothyroidism. So people that didn't have that, and those who are here, I'd really love to hear, what was your diagnosis? What were you told was the reason you needed to be on thyroid meds for those who are? How many of you were actually hypothyroid, meaning your T4 was below range and your TSH was severely elevated? Now, I want you to hear, because this is an important distinction. I'm not saying that's the only situation in which your thyroid can be affecting you. And I'm not saying that no one else should be treated or helped out for their thyroid. But I'm just asking, if you're in that category or not in that category, just state either way, what was your diagnosis, if you don't mind sharing? So in this study, they took those that didn't have overt hypothyroidism. They had subclinical disease. And of the 291, they had them go through a taper process by which their medicines were just dropped over the course of 6 to 8 weeks. And they watched to see if they stayed stable and how they felt. It turned out to be the case that 60% of people, 60%, were fine. They had no real effects from that. They stopped the therapy and they were no worse from it. So that was one big study. Now, here's another one I'm going to talk to you guys about that was related. So here's how that played out. This was the proportions of those who were stable without medication was that big blue chunk, and the others were not. So yeah, the majority of them didn't even need it. They didn't feel any worse for being off of it. So here was one in which it looked at that same question and looked at it in more depth to see of people who did discontinue, what was different about them. And in this one, they took 382 people, and they had a mix. Some were overtly hypothyroid, some were not. And of them, 22% needed no medication, 58% needed less. So basically 80% could discontinue with no drawbacks. And the study was interesting. What they showed was that one of the big factors they considered was iodine. And they showed that, yeah, subclinical disease is more common in places that have adequate iodine intake. And they did also encourage iodine restriction as part of their process. And yeah, they saw that 80% of people on medication could do fine with less, and a big chunk needed none. Hey, Holly, good to see you here with us. Welcome, welcome. And so here's a quick synopsis of some of these studies. So patient selection on the right, for those who can see the image, what they saw was that if there wasn't a clear diagnosis at the time treatment was started of hypothyroidism, then many didn't need therapy. So that was a big distinguishing factor. Those that had subclinical disease, or they were given medication to see if it would help, they often didn't need it. When they stopped it, they felt no worse from it, and their thyroid levels were just as stable. So yeah, that was pretty dramatic. Okay, so we've got a lot of good questions and comments that have been rolling in. Let me just take a peek at a few more of these. So here's some comments about some diagnosis. Melissa was on the borderline of 4.0, I'm assuming for TSH, and just got pregnant. Doctor wanted me on it for pregnancy and haven't been able to get off it since for over 5 years. Yeah, that's an interesting situation. So in the case of pregnancy, there is data arguing that you can be healthier with your TSH being a little lower than 4.0. So that could have been a judgment call. But then the question is, what's needed long term? Lisa's here. We'll talk a bit about that. Joanne's here. Hey, Joanne, how you doing? Good to see you as well. I'm taking a peek over at Instagram as well. Let me just stay on top of some of the comments. Yeah, I'll start diving into some questions here as well. Our friend from Iceland, I'm so curious about your version of Insomnia, if that was more detail you have, because it didn't quite fit. And F. Mavic, I see you here a lot. I don't know a proper name, my apologies. Can one develop a thyroid problem from too much iodine without having a diagnosed thyroid problem? So let's break that apart a little bit. So I guess part of that question is, can somebody have a thyroid problem without being actually diagnosed as having one? Which sure could be the case, yeah. And that would depend upon Felicia. Okay, Felicia. I'm going to even make a note. I'll do my best to remember. I'd like to prefer to use names. So Felicia, thank you for that. And thank you for being a regular here on Office Hours. Always good to see you. So yes, you could have a thyroid problem without being diagnosed as having one. And that's one of the big things here is that many people are not thoroughly tested. Their tests aren't thoroughly interpreted. And they can have disease for some time before it does get obvious. So that can definitely happen. And as far as too much iodine driving that, yeah, that's possible. And the two versions of that, there's iodine-induced hyperthyroidism. That's most common where someone is prone to Graves or toxic nodular goiter, and a big dose of iodine pushes them over the edge. The other thing is called the Wolff-Chaikoff effect, and that's where a lot of iodine just shuts down the thyroid. And that's kind of odd, but I don't know if anyone remembers back when we had the Fukushima disaster many years ago, there was a lot of talk about the use of iodine supplements. There was one product called NORAD, and that was a potassium iodide supplement. And the reason that that's given in some contexts of exposure to radioactive iodine is because it shuts off your thyroid. It shuts it down for many weeks. And if you know you're going to be exposed to radioactive iodine, that could make you less apt to have that stuff end up in your thyroid. So yeah, high dose iodine shuts off your thyroid. And in some cases that's useful. Normally we don't want our thyroid shut off. But yeah, I won't go through all the mechanisms about how that happens, but short answer is you're right. It can certainly be a factor for that. Let me grab a couple other questions that have come in. Let's grab this one here from Barb. Can you please explain more about the pre and post standardization process for the compounded NDT? Yeah, Barb, and let me just expand a little bit. So for those who hadn't heard, I think a month or so ago, I had mentioned that there were now some better options for compounded NDT. And even more context, natural desiccated thyroid, also called desiccated thyroid extract, common brands like Armor, NP Thyroid, Nature Thyroid, they're pig thyroid, and they've got a variety of active hormones that aren't found in the synthetics, including T2, which I just wrote a new paper about. But yeah, many can do better on it, and we've had a lot of problems with just back orders, with product recalls, with availability. So a lot of people who've done well on NDT have had a hard time getting the brands they wanted. As a generalization, I'm wary about compounded thyroid meds, especially the synthetics, and mostly the issue is that it's tiny amounts that are being compounded. So the case of a synthetic thyroid medication like T3 or T4, the problem is that the active ingredient may be the thing they're measuring. And if you notice, like for example, if someone's on T3 or T4, the potency is in micrograms, like they're on 100 micrograms of T4 or 5 micrograms of T3. And now natural desiccated thyroid, the potency is milligrams. So it might be like 60 milligrams or 97.5 milligrams. So is that 1,000 times more? It's not. The difference is that the milligrams are the milligrams of desiccated thyroid powder, and that contains a few micrograms of active hormone. So with synthetics, all there really is the micrograms of active hormone. So when that's compounded, there's so much room for error. Now, compounded natural thyroid, desiccated thyroid, is a little better because they're compounding a powder which is about 1,000 times more dilute. So there's less room for error, but there still can be issues based upon the raw materials. And the raw materials have guidelines that have to be standardized when they're tableted, but it's not done by all compounders. So what I was saying before is that those who did prefer WP Thyroid or Nature Thyroid, the powder that made those products is now being made by some compounding pharmacies. And I want to say I'm not tied to any pharmacies, compounding or otherwise, so I'm just sharing what I've learned, what I think is helpful. But this is nothing that I'm committed to or I want you to feel committed to. A local pharmacy in the Phoenix area called Foothills Pharmacy, they have been purchasing the powder that has been used to make WP Thyroid and Nature Thyroid. And what I feel good about is the fact that they have certificates of authenticity and certificates of potency when they get the powder. And I've seen those certificates. So they analyze for purity, they analyze for active hormone content. So what happens is then when they know that, they can make small adjustments as need be. So let's say that the batch of powder is 95% of potency. And that's acceptable. It could be used right as it is. But when they know that, they could add in 5% more powder to compensate. So it could come out even better than it would have in the normal tableting process. And then there's also a post-production assay that they've done to confirm that the final product was at the target. So it's been a good process. Now, the only thing I don't like is that this is not a process that everyone does, that all compounders do. So this is one pharmacy that I know is doing that, and I'm saying them because I know about their process. It's almost like, if you get a burger at McDonald's, you know what you're going to get. It's not great, but you know what you're going to get. When you go to a small local restaurant, it might be awesome, might not be, right? So that's kind of like compounding. And this is a case where I know of one chef who's got a good recipe and a good process. But I can't say that they all come out the same way. But yeah, this is one where I know that it can work well. So yeah, Barb, please throw some more comments up if I didn't quite cover what you were hoping to hear from that. I'm happy to give more depth and clarity, but I think that would have made sense of it. So let me grab another question here. So here's one. And not much of an answer, but Cindy, if you want to give more details, if I could grow back my thyroid. So Cindy, if yours was completely removed, I'm assuming that's what you mean. I don't know if you meant if it was surgically removed, the whole thing, part of it, or if it just shrunk over time. If you want to give more details, actually, I've seen you before. I think yours has been removed. And yeah, no growing back. This is kind of interesting. There actually has been research about the use of thyroid stem cells to cause a regrowth of thyroid tissue. And it's been done in animal models. There actually was a human study. And for a proof of concept, it can work. Now, the drawback is that most people that don't have a thyroid have autoimmune disease. So the concern is just that if you could have someone regrow their thyroid, if they hadn't reversed the autoimmunity, they might break down the new stuff too. So far not commercially available, but there have been studies, and it's a plausible idea. So if one really could determine and isolate the driver of autoimmunity, like for many people it is iodine, but if you really knew the process had calmed down, that could happen. There are already some ways by which the technology could allow for that to happen. So maybe. Let me take a peek at Instagram real quick. So Davy Boy rides bikes. Hey, Davy Boy. Switching from 60 milligrams of NP thyroid to 100 micrograms of tyrosine. Wondering what I should look for in my next labs. That's a great question, Davy Boy. So yeah, this is a funny thing. So you're going from rather equivalent dose to rather equivalent dose. That's assuming that your levels were about where you wanted them on that 60 milligrams of NP. That's about where you would change going over to tyrosine. Now, they are, to some extent, apples and oranges. So we need to have some ballpark idea about how those potencies compare, and that's about how they compare. But they are apples and oranges. So the big thing I would say, Dave, is that please do check your labs pretty quick, like a couple weeks out, 3-4 weeks out. Know that they're not yet leveled out, but at least look for the changes. And expect to check a few more times afterward. It's quite possible you could need a dose very different than that 100 micrograms on tyrosine. That's probably the most reasonable place to start, but you could need more or less. It's entirely possible. And it could also be just fine, But if it weren't the exact amount you would need, I'd hate for it to take a long time before that got discovered. So check again. The other big thought I would put out is I wouldn't really judge how that medicine worked for you until your levels were stabilized. I think a lot of people, it's easy to change medicines and find that your scores are way off and feel like crap and think, oh, heck, this is not the medicine for me. And that really seems like it would make sense. But yeah, if your levels are off, the medicine honestly might be great. But if your levels aren't right, you wouldn't yet know that. So if you are going to give it a fair chance, which I think is reasonable to do, get your scores dialed in, give yourself several months of being there, and then really consider how it's been working. But don't judge before you've stabilized and had some time to be at that. So between NDT and T4, NDT has a few more active hormones. T4 has fewer. Tyrosine can be well absorbed, and many people can convert. So not everyone can, but many can. And really, I think more about a medicine that you can get regularly, you can get stabilized on. I think those are more important than which medicine you're on. And having said that, I know without a doubt that many people only do well on one type. I get that. But if someone is just not sure, I would really see how they do on something they can access before they judge if it's the best fit or not. So hopefully those are some useful thoughts. And Davey Boy, a few more things. All your hormones are important, and in testing, the TSH is the first thing to change, and it's 50-fold more sensitive than your T4 and your T3 are. What I mean by that is, if your TSH is way catastrophically off, eventually your T3 and T4 will mimic that. They will do the inverse of the TSH. But they're not the most sensitive indicators because your body tries to make them stable. The TSH is really where you want to go. The minute you've got more or less than you need, your body adjusts the TSH. But it's only when you can't control the T3 and the T4 that they change. So they're not the first things to change. And kind of like what I said about not judging the medicine when your scores aren't right, don't judge the other hormones if your TSH is not right. So that's a bit for you and your doctor. But yeah, definitely get your TSH steady before you judge too much else for the rest of it. Okay. As long as I'm peeking at Instagram, let me grab one more here from there. This is from Holly. Good to see you back, Holly. Thoughts on Maca powder if it's thyroid friendly? Yeah, Holly, I've researched on Maca, and there's actually a quick update. I'll tell you guys this in advance. So I'm launching a massive amount of training for you all starting in probably November, like end of October, beginning of November. So I spent a little over a year going through all the medical literature on things that help thyroid disease. No joke, as a full-time job. It was about 40 hours a week for about a year. And the thyroid reset diet, that's one of the things that came from that. I just was blown away at more depth about the iodine story. It was just fascinating. But a lot of other things came of that too. There's a lot of things that I learned that were more applicable to practitioners. And that's why I founded the American College of Thyroidology here this last year or so. Well, there's a ton of things I learned about nutraceuticals, and there's been a lot of great research that no one has made use of. So I'm going to educate you guys like crazy about that starting in roughly November, because I've had this massive pile of data. I had to do the book first because I was committed to that with the publisher, but I had no joke, the book was supposed to be 75,000 words. I had about 300,000 words of content. So I had way too much for the book. So I pared down, did the book just about the diet, and now I've got massive amounts of content about nutraceuticals, these things for practitioners, the comorbidities. I've got a lot of stuff to still do from that year's worth of research. But yeah, I've got a lot of things top of mind about nutraceuticals, and that's a ton of stuff is coming out in November for you guys. So stay tuned. I'll have about 10 weeks back to back. I'll do a quick overview of it just so you can make use of it at the very beginning. But then I'll do about 10 weeks back to back of just massive in-depth data on various goals and how you can help them. So stay tuned. I'm working hard on that right now and putting the finishing touches on it. Very excited about it. So that was a long rant. But Holly, your answer to Maca. So I wanted to get some context for your answer to Maca, Holly. So in all my time reading and all this stuff, I didn't get all that excited about Maca. I mean, there's nothing bad about it, but I didn't see a lot of compelling evidence for it, good, bad, or sideways. So it's a pretty food-like thing. I would put herbs on a continuum to where you've got some things that are really exacting and potentially toxic and potentially useful, but they've got to be just the right circumstances, like microscopic drop dosing, aconite, belladonna, there's some stuff like this. And there's other things which, might as well be carrots. You're not going to get hurt from them. They can be useful. They're very nutritive. They're very supportive and safe. And Maca is quite a ways over on the carrot side. It's been used like a food. I've not seen data suggesting that it's harmful for the thyroid. I've also not seen data about it doing anything, any evidence of it doing anything all that dramatic yet. So it's not something that I'll be talking about in my big share of information, but I have certainly read up on it. And yeah, I wouldn't be afraid to throw it in every now and then. I also wouldn't see a strong reason to do so. But that was my take on it. Let's see. Learning Together 56. So this is a great question. Why do some people recommend iodine for fibrocystic breast? Thank you. So get yourself comfortable. I'm going to do my best to give a quick answer. Well, I can give a quick answer. So the thyroid concentrates iodine. There's a thing called the NIS, basically the iodine pump, the sodium iodide symporter. Now, the breast tissue has that symporter as well. It also concentrates iodine. There's a spectrum of how active that mechanism is in breast tissue. So male breast tissue, women's breast tissue that are not lactating, there's not much going on. There's not a lot of iodine concentration at all, actually like none. So the highest part of the spectrum is with hormonally sensitive breast cancer. That's where there's the most concentration of iodine, and I'll come back to that. Now, the next step up from none is lactating women. So when a woman is making breast milk, she will concentrate some iodine in that breast milk. And this is the same reason we concentrate iodine in the thyroid, because the blood levels are not enough. We need more than what's in the blood. So we concentrate it up a step and we can control it. And if mom's milk just had the blood levels, they would be too low. So that steps it up a little bit. Now, between lactating breast tissue and breast cancer is fibrocystic breast disease. That's a higher expression of iodine concentration. Now, earlier in today's discussion, I talked about iodine shutting off your thyroid. Well, it does that because it shuts off the pump. It shuts off that sodium iodide symporter. So if you've got fibrocystic breast disease and your breast tissue is concentrating a lot of iodine, and that extra iodine is causing free radical damage, it's causing swelling, it's causing localized pain, well, if you flood your body with iodine, you shut off the pump. You stop the pump. Now, a doctor that was a kind man, he's deceased, but he started so much of the iodine legends that still go around today. He saw this data. He was a gynecologist. He didn't have a strong background in nutrition, but he confused this data for thinking that iodine helped because the women with fibrocystic iodine were iodine deficient. And so he thought that they must have needed that high dose of iodine to feel better. And it was an understandable mistake, but it was a mistake. If anything, we know that the truth is pretty much the exact opposite, that they were concentrating too much iodine. And iodine helped because paradoxically, iodine can shut off the body from concentrating iodine. So that's why it was useful. So to come back to that, there have also been many who have gotten into this iodine lore that he founded, and they've speculated that iodine would be protective for breast cancer. And the sad thing is, in this case, we also know that's pretty much the exact opposite of the truth. They looked at data on Japanese women and saw the real data that many Japanese women on traditional diets had lower rates of breast cancer. And they often had higher intakes of iodine. So many assumed that the one caused the other. Well, a couple problems. A big obvious one is that it wasn't the only factor. They were also, as a group, lower in body weight. Also, as a group, they had a higher intake of plant foods and cruciferous foods. They also had a higher soy food intake, green tea, low alcohol intake. So a lot of group differences. But a big thing they found, though, is that amongst Japanese women that do get breast cancer, those who are highest in iodine are most likely to develop breast cancer. And this has actually shown up in other cultures now as well. And there's also been talk about using iodine levels as screening tools for breast cancer risk because there's that strong of a relationship. So learning together, that's the idea. People really didn't understand that iodine helped, not because the body needed iodine, because it shut off that process. So the drawback is if one would use iodine for fibrocystic breast disease, you can benefit symptoms short term, but you probably worsen the risk for developing breast cancer. And the same mechanism doesn't work for very long. It becomes self-limiting. So I call that the difference between a nutrient acting as a drug and a nutrient acting like a nutrient. So, niacin's a great example. If your diet consists of only highly processed cornmeal, you could be deficient in niacin. You could get pellagra, and niacin could reverse that deficiency. On the other hand, megadose niacin can lower cholesterol levels. It actually blocks the same enzyme that statin medications block. Now, it wouldn't be accurate to say that niacin deficiency causes high cholesterol, right? You guys see that difference? So niacin as a drug in doses far above what we need nutritionally may block cholesterol output. Doesn't mean that it's good or healthy or that it lowers heart disease, but it blocks that one enzyme. That's not the same as niacin as a nutrient. And so same thing with iodine. It can do a lot of things as a drug that don't relate at all to what it does as a nutrient. So if that was useful, if that didn't totally make sense of it learning together, put a follow-up question. I'll go deeper in that. But good question. Happy to address that in some way. Okay, let me get Kim's question. Thank you, Kimberly, for patiently waiting here. Graduation day for MRD. So awesome. Good job. Got my blood drawn this morning. Could you please tell me the optimal numbers I'm looking for when my report comes back, please? Yeah, Kim. So let's take a peek at a couple things. Now, one big thing, and I'm so glad you asked, morning fasting glucose levels right after weight loss for people can often be higher. So you can do things that make you completely healthier, and your morning fasting glucose can be higher for a little bit. So I want to put that out there. Anyone who's finishing the MRD, please do not panic. Happens all the time, totally understandable, but it's normal. So what's happening is that as the liver gets more triglyceride out of storage, it's better at forming glucose. So the morning fasting levels may be higher. They're often not, but sometimes they are. So it's more important in that case to look at the 3-month glucose average, which is called the hemoglobin A1C. So check if your glucose is checked and it were higher, take it with a grain of salt, but also consider you could have looked at the A1C if need be. So the A1C shows a 3-month average, and it's less sensitive to short-term fluctuations. And people often see very dramatic improvements. And that's actually what started the whole MRD itself. That was a program I used for reversing diabetes for a decade or more, decade and a half, I guess. And we took many people who were badly diabetic, uncontrolled on multiple medications. We would do the MRD, have them under controlled clinical settings when they're supervised by us. We would stop their meds on day one, not when they graduated, but on day one. And at the end of it, we would commonly see normal non-diabetic blood levels, not on medication. So super exciting. So that was about the blood sugar. Blood triglycerides often can improve as well. Ideal levels for those for morning fasting would be less than 150. An A1C, we love to see that below 5.7. Low fives is great, but it does take time to completely shift because it's a 3-month average. So if your A1C was higher than ideal, it can come down in the course of 4 weeks, but it won't yet be plateaued. So any big change in it is encouraging. Now, the other thing we think about is liver function tests, and specifically the ALT, the alanine aminotransferase. We love to see that below 19 for women, below 25 for men, and that's another big thing that commonly changes with the MRD. And that's also one of its big uses is reversing fatty liver. So fatty liver, prediabetes, stubborn weight, they all just go hand in hand. And those are all big things that change. So yeah, some cool things to look for shifting. And Kimberly, waist circumference inches is probably as important as any of those other things, maybe even more important. So the stuff you can find out on your own with a tape measure in the bathroom, it can be more significant than the complex medical tests. It's a stronger predictor of longevity and cardiovascular death than any test you can think of. So that's a hugely valuable thing. Morning fasting heart rate is also a good change that commonly improves for those on the MRD. Easy thing to measure at home. But yeah, those are some big ones. Okay. Wow. So here's let's see, I'm just kind of picking through here, you guys. Cindy. So Hashimoto's thyroiditis and hypothyroidism, several large nodules. Oh, Cindy. Yeah, so you had a question before, Cindy, about wishing your thyroid could grow back. The tricky thing is, it still can improve. And actually, Cindy, we got a note from someone a couple days ago. This came in through social media, and this woman started the thyroid reset diet in January. And for 15 years, she had been tracked with multiple large nodules. And it was a big stress. It was a big concern. And she just got her ultrasound back after starting it in January. And she had none. She had no nodules for the first time in 15 years. And she was super happy about that. So those things can change. They don't always. I don't want to say that always happens to everyone. But those things can happen. And even with that, those circumstances, Cindy, your function could improve. If you're on medication, those needs could change and you could do better on what you are taking. So please don't consider the diagnosis destined to never improve or never get different. So, yeah. All right. I'm scanning through. I'm going to grab a few more questions. I'm just kind of picking and choosing, and it's hard to choose. There's a lot of really good ones for you guys. Thank you for that. I'm trying to mix it up with. Okay, so and I also do follow-up questions when I can. So some follow-up questions. So here's a follow-up one that Barb had. So the raw material powders, what's pre-standardized, but a pharmacy can do a post-assay to add more. So that sounds darn close, Barb, and that might have been how I communicated it. So the only thing that was different is that their post-production assay is not what they're using to adjust they can adjust the ratio of T3 and T4. It's the quantity of active hormone, the total quantity of active hormone. The ratio is really just set in NDT, and the ratios are pretty consistent from batch to batch. So they're looking at the assay when they buy the powder that shows how much active hormone there is per gram of NDT powder. And they can then use a little more or a little less powder as it would indicate. Once it's all said and done, they can take samples from batches and repeat an assay to make totally sure it all came out as it should have. So you basically had the right idea, but I'm OCD about details with things like this, so hopefully that clarified it. And then again, follow-up questions, I love them. So if I have no problem filling my NDTRX, do I really need to worry about change? No, you don't. And this is a great concept in general, Barb. If what you're doing is working well, I wouldn't push you to change it by any means. If you're on a kind of medication that's working well for you and you're functioning well from that, I wouldn't push you to change. The topic that I had at the very beginning was just for those who are asking if they could need less medication or need none. And what we've learned is that the answer for so many more people than we ever thought is probably that there's a lot more people that don't need to stay on medicine or could do pretty well on less of it. So that's been fascinating. So here's a quick one. This is with our friends on YouTube. Been introduced to naturopathy just recently. Since then, I've been following you and now also a fan. Keep saving lives. That's awesome. Thank you so much for that. Joanne, all set for the Boston Marathon. I'm rooting for you. Thank you so much. I am. And actually, it's 2 weeks from today. So super excited. It's been a lifelong dream. I've been a frustrated on and off athlete. My own orthopedic health issues have gotten in the way of my running career for many, many years. But I've had a good sequence of training. And yeah, I qualified, got in, and really happy about that. Another quick question, or related question, trying to find these. I would like to try WP Thyroid. I'm in Arizona. Is there a pharmacy here for NDT compound? Yeah, so to be really precise, it wouldn't be WP brand when it's compounded, but Foothills Pharmacy, again, I'm not pitching for them. They don't pay me. They are using the powder that was used to make WP. So that's one way you can get that. They're in Mesa. They ship to all but 2 states. I'm pretty sure it was Mississippi and Alabama. I'm pretty sure. But yeah, they ship to all but 2 states. They can be used wherever. Related couple other questions. Let me grab a few more here. I'm just going to scroll back to Instagram. Learning together. You explain everything so we understand. Thank you. You're welcome. That was the fibrocystic thing. I'm glad that made sense because that's a topic that, it's really, if you walk through it, it makes sense, but it's very easy to have it intuitively go wrong. And that's what's happened to a lot of professionals. Okay, so here's a great one too. I have been diagnosed with hypothyroidism, and a year before that, I started taking Nutrafol supplements for hair loss. After reading your book, I got my iodine levels tested. They are at 50. Okay, so let's hide these real quick. So you got your iodine levels, they were at 50. So from the units you said, I don't know how that was tested. That was probably serum, I'm going to guess, because that's kind of a common range for a serum iodine to be. Please read the book a little more closely about iodine testing. Your testing levels don't really... The logical question is, I don't know if iodine caused my thyroid to go wrong, so I'm going to test my levels. And if my levels were high, maybe it was the problem. If they aren't, it's probably not relevant. That's so logical. Okay, you clarified for me. Random urine test. Thank you for that. So 50 for a random urine test. So the units are micrograms per mil that show up in micrograms per liter of urine. And yeah, so logically you'd think that if your iodine was high, this might be an opportunity to help your thyroid. But the studies that were done on low iodine diets, several of them, they would take people, big groups of people, they would do the diet, they would see a bunch of them get better, they would see some not get better, of course, and some of the studies looked at iodine tests. And then after the fact, they put people into, okay, here, these got better, these didn't get better, and their iodine levels beforehand, did they predict that? And you would think that those who had high iodine got better, and the ones that failed to improve were the ones that already had low levels of iodine. But it just wasn't the case. It just doesn't work that way. So the iodine in our thyroid doesn't have that tight of relationship to the iodine in our urine or the iodine in our blood. So yeah, the tests are not predictive. So the good side of that is if you've not attempted the thyroid reset diet, because of that, it still might be useful for you. But yeah, your iodine levels don't really predict your likelihood of success for that. I wish they would. That would be simple. That'd be an easy thing, but they just don't. If someone does do the diet for a few months and they don't, there's a more detailed version of the iodine test that may be useful. And the reason for that is it can help you see maybe you're still detoxing. If your iodine levels are high on urinary iodine to creatinine ratio, if you're above 100 micrograms of iodine per gram of creatinine, and you've been on the thyroid reset diet, it means one of two things. It means you're missing something, there's still some iodine coming in somewhere, or it means you had a massive amount and you're still detoxing it. And just from that test, you can't distinguish the two, but it just takes thinking it through and thinking, how long have I been on this? Was I on a really high dose of iodine before? Maybe there are some things that I wasn't doing 100%. You can often just tell by thinking it through. But yeah, if you've gotten a ways into it, you're not getting better, you can do a urinary iodine to creatinine ratio test. It's not the same as a random urinary iodine. It's not even the same as a 24-hour urine iodine. But if it is still high, then you've got still some opportunity. If it's well within target and you've been there for a while and you haven't budged, it probably won't help you, unfortunately. But if it's still up, then maybe something still that you can do. Oh, hey, Holly. When do you think you'll have doctor recommendations up on actthyroid.org? Yeah, great question, Holly. So we're still getting up and running. Yeah, we just got going in May. We've got, and you know what we actually can do? Thank you for that. There's no reason we can't get a listing up for current members. We've got 3-4 dozen members, and I know we were in the process of getting them visible on a page, and we can do that. So yeah, we are also going to be certifying DACT fellows, so diplomates of the American College of Thyroidology. That'll be at least 2 years out because that's a big process. But what we're going to have is we'll have a listing of ACT members and then also DACT fellows. So the DACT diplomates, we'll have both of those available. But yeah, the diplomates are 2024, 2025, but the members, I'll see if I can't pull the trigger and get that going in the next month or so. We should be able to do that much sooner. So yeah. And Felicia, again, I'm going to remember, is it safe after the 2-week break on MRD to go right back into another reset if you have more interest to go? It sure is. No problem. I think that's exactly how you would play that. You give yourself a couple weeks off. During the couple weeks off, it's pretty common to stay on track, maybe just drift up a few pounds. And it doesn't mean you're going to keep on drifting up. That's pretty common though. But don't be worried or alarmed if you do go up slightly. But yeah, take a few weeks off, let your body regroup, do more exercise, have a few more solid meals. And if there's further you want to go, then dive back on in. That's exactly how you would do that. Let's see. Oh, here's a cool one. This is from Tasha. So Tasha was diagnosed with hypothyroid. Oh, okay. Thank you, Tasha. So this is a good distinction. So Tasha had a low T4 and a high TSH. This is overt hypothyroidism. I want you guys to catch this difference. So most people who are put on thyroid meds don't have overt hypothyroidism. They have subclinical hypothyroidism, or they have suboptimal thyroid levels. And please hear me, those things are real. They do matter. They still can be relevant, but they're not as likely to improve on thyroid medication. That's the big difference. But Tasha was overtly hypothyroid. And let's see, also then diagnosed with autoimmune thyroid disease, since being on the thyroid reset diet, has been able to decrease medication. And thyroid antibodies are coming down. So this is perfect. So yeah, and I want to echo a statement I made earlier to someone, is that even if you've got the more overt versions of disease, people can often get better. In the clinical trials on the thyroid reset diet, they showed that even in those cases, those that were not yet on medication, that roughly 80% could fully reverse the disease process. So yeah, people can get better. Let me get a little more depth, and so I'm with you guys on several platforms, and when I'm talking with you on Facebook and on YouTube, I have the option of just showing your questions so others can see that as well. And someone earlier said, please don't show my question, but they asked one, and that's totally fine. So if you want me not to highlight your question and make it visible, just say that in your comment, and I will completely respect that. So here was another related question that we got about this topic of subclinical. So Rochelle is saying, what is subclinical? I was recently referred to an endocrinologist. And actually, Rochelle, the funny thing is that I can't read the whole question when it's displayed. Oh, maybe because it's highlighted for me and blocked. Oh, here we go. Results are based on 2 tests. TSH was 6.2, thyroid peroxidase 13.5. Could be underlying autoimmune leading to hypothyroid. Started thyroid reset diet. See if I can turn things around. And we'll see the endocrinologist in November. Would like to stay off meds if possible. Hoping I'm in the subclinical range. You are, Rochelle. And again, even those who are not subclinical, many, 80%, have reverse thyroid disease with the thyroid reset diet. So yeah, but that is the subclinical range you're talking about. So subclinical disease is where the TSH is high. Generally, they consider it below 12. Some say below 15. So it's up, but it's not completely through the roof. And the T4 has not dropped below range. The T4 or free T4, they can be low normal, but they're not below range. If you have a TSH that's very elevated and the T4 is below range, that's then overt. So yeah, that's the difference. And Rochelle, you've got heck of a good chance for doing better. So good question. Okay, let's see. Oh, so many good questions, you guys. What pharmacy? I'm in Arizona. Okay, so again, I'm not working for anybody, and I almost feel bad saying this, but it probably can be useful for some. So Foothills Pharmacy, and your doctor can prescribe to them. The doctor would prescribe NDT powder. The doctor can choose the potency. That's a cool thing about compounding. And they can then receive the powder that would be made into WP thyroid or nature thyroid. I saw a follow-up comment of Cindy's that I misread before. So it was complete thyroidectomy. So Cindy, sorry, I misunderstood. So no, that wouldn't reverse. I actually have seen that, believe it or not. We have had someone that had a complete thyroidectomy that had their thyroid grow back. That's extremely unusual. But nonetheless, we can still see these same steps often help people that have unresolved symptoms. Cindy, an important consideration is that there are also what I call the comorbidities. There's other conditions that can cause symptoms for people that have thyroid disease that are not thyroid disease, but they commonly overlap. So it's important for the doctor to know that yes, optimizing your thyroid is critical, but you may not totally feel your best if there are hidden comorbidities. So some big ones, latent iron depletion, celiac disease, parathyroid disease, sleep apnea, fibromyalgia. Actually, obesity itself is a comorbidity, depression, but there's about a dozen of these. I've got more content on that coming out in the near term as well, but that's a big thing to think about towards feeling your best. Okay, so a lot of good questions, you guys. And let me try to get some related ones. So Sarah, does maca contain too much iodine? Sarah, I haven't seen a lot of assays either way. If anyone has, I'd be curious to know because I would pass that along, but I've not seen, just in general in terms of root plants like that and not being a coastal plant, that wouldn't be expected, but I've not seen data suggesting that. So yeah. So here was someone that said, please don't display my comment on screen, no problem. Are you going to be shipping to Canada soon from your website? I would like to try some of your products. I would love to, and we keep looking at that, but it's a tough process. Health Canada importing things, it's prohibitive for us at this point, unfortunately. So the workaround that some people do is that some people have friends or relatives in the States that can ship to them. And if I was your uncle, I could ship you something as your uncle, but I can't ship something to you as a business. But yeah, some people will have a friend or loved one in the States that orders on their behalf and they then ship to them. So that's an option that some do, but we can't directly just yet. We would love to, but it's very prohibitive, unfortunately. So my apologies. Okay, several good questions, you guys. So, and again, I'm trying to get follow-up questions as much as I can. Noreen, which one do you like if patient needs to be on desiccated thyroid, Armor, NT, or Nature Thyroid? Well, Noreen, yeah, I grabbed your question because this is related to the discussion we were having. if someone's already on a brand and they're doing okay accessing their brand, I wouldn't push them to change it. So Noreen, if you were on Armor, that's the one that's been most stable for availability as of late. Thyroid, NT, I'm guessing you meant NP, like Nancy Paul. NP thyroid is different than Thyroid. If you were on NP and you weren't having availability issues with it, I also wouldn't really push you to change. Thyroid, if you do have it, you're on borrowed time. It's tough to come across. So yeah, the only reason I'd push someone to change is because they couldn't get their preferred brand. All factors equal, any of those are fine, but the availability is a factor. So right now, Armor is the easiest of those brands to obtain. The one drawback is that it's the least cost-effective of those brands. It's not better than the others. It's not worse, but it's the least cost-effective by a pretty big margin. So yeah. And okay, really good related question. What about OTC bovine thyroid? This is from Ranchy. I think he even told me your proper name before. My apologies. But yeah, so OTC bovine thyroid. Yeah, so there's a ton of things you can buy, of different products you can just buy that are like Thyro Gold is one product name. And yeah, these are bovine thyroid. They're non-prescription. Carla, okay. Yep, I think I've seen you before, Carla. Thank you for that. So yeah, they're out there. And there's a wrinkle to the story, which I'll share with you also, which is totally bizarre. But these products exist. A lot of them will say on their marketing literature that they don't have active thyroid hormones. Some of these products, if you get into discussion groups or if you ask the sales representatives, they will quietly tell you about how potent they are compared to natural thyroid. They have active hormone. So I say that because there have been a couple times in which researchers have just bought these products like you or I would over the counter, brought them back to laboratories, and then assayed them for active hormone content. They have active hormone. In the amount they have can be all over the place. Some have a lot. Some have literally 50 micrograms of T3. Some have 100 micrograms of T4. And it's inconsistent from pill to pill in the same bottle. So if they were standardized, you could theoretically say, oh, about this much works for me. But they're not consistent, even within the same bottle. So that's one big drawback. Now, two more wrinkles, I guess. So one wrinkle is that there are a ton of thyroid support supplements on the market. Let me back up a step. I'm sorry. So one of these studies took the glandulars you're talking about and analyzed them, and that's the stuff I was talking about. Let's put that over here. Now, another study took a whole bunch of thyroid support products, some of which had bovine glandulars, some of which did not list bovine glandulars among their ingredient list. And they had 10 products in this particular category. Now, of these 10 products, 9 of them that didn't list bovine glandulars had active hormone. So either they really did have bovine glandulars or somebody snuck in some T3 and T4 in them, but they had active hormone. So yeah, so thyroid support products can have active hormone, but no one tells you how much. It's never consistent how much. So that's one big wrinkle. Now the second big wrinkle is that these bovine glandulars, so bovine means cow, right? Porcine means pig. Canine is cow. I forgot the fox one. Vulpine is fox. There's some fun descriptive adjectives. I won't get too far down the list on those. I don't know that many anyway, but so yeah, bovine is cow. So what we're talking about is stuff from cow heads, right? So there's a thing called mad cow disease, also called bovine spongiform encephalopathy or Creutzfeldt-Jakob syndrome in humans. And this is a prion-based disease. So as rightfully as we fear viruses, we could fear prions even more because they are undetectable. They can do nothing. They may do nothing for 15 years, and they can turn your brain into jello. And I'm not exaggerating that. I have a dear friend that lost his wife to one of these diseases. He's a doctor. He's now made this his mission in life to work with these conditions. But this is the scariest stuff going. And there have been cases of this caused by prion contamination. And you can get prion contamination in any products that have bovine glandular tissue from the head or the neck. So I would never I think taking bovine glandular products, it's a version of Russian roulette. And this is the case where the trigger might not get pulled for 15 years. So I wouldn't take those at all. So even if they did kind of work, even if they were decent options, I wouldn't take them because of the prion risk. So yeah, that's my rant. So desiccated liver, Carla, has nothing to do with this. I won't go into whether that's good or bad or sideways, but my concerns that I stated about prion disease would not at all be a concern I would state about desiccated liver. So none of this stuff is in liver tissue, in cow liver. But stuff from a cow's head, stuff from a cow's neck, wouldn't touch it. You wouldn't get me to touch it for anything. Yeah. Okay. How are we doing here? I've got to get supper going. Let me grab one more. There's so darn many good questions. Norma, just a quick one here. I'll get two more questions. Yeah. Diagnosed with mild cerebral palsy at the age of 52, explained my life, lower body weakness, painful body muscle spasms. What do you suggest to cope and reverse symptoms? Yeah, Norma, I grabbed your question because I'm 52 now, and I know that that's been a big part of my struggle. And I don't have any answers besides just movement and lumping it and keeping going. Finding ways you can move your body that... I wouldn't say finding ways that don't hurt you, because sometimes they do hurt you, but they don't have to hurt you in ways that progress. Exercise, when it works well, it may not be fun in the moment, but you shouldn't have bad hurt and you shouldn't have lasting hurt. And that is a function of experience, unfortunately. I can't think of an easy rule to distinguish those things. Working with good physical therapists, with trainers, with guidance, and being able to learn, what's good hurt, what's bad hurt, and then just sticking with it and progressing. And cerebral palsy has such a broad spectrum of ranges of manifestation. Some people can barely function at all. Others are barely affected, and there's a full continuum. I have no idea where you are in that, but it's remarkable how much the body can get better from just persistent, good exercise. And the amounts that are helpful are often uncomfortable, and again, there is a point where you can be doing so much that's not productive, but that takes time to figure out where that line is. And it's always a work in progress. Joanne mentioned Boston Marathon. It's 2 weeks from today. So yesterday, my training program had me scheduled for my last long run of the 25-week cycle. And it was a 19-mile run. It would have been a horrible idea. I did a couple of similar runs in back-to-back weeks before then. I wasn't recovering as fast as I had hoped. They had totally wiped me out, and I was pretty tough shape for a couple of weeks. I was not at my best in terms of my training or energy levels. And so I knew that I had to course correct and adjust the program. And so I didn't do that long run. I did a casual one on a trail and was out for an hour and a half, and it was exactly right for me. So it's a work in progress, but stick with it and just know that the body can do so much more than you would think. So hopefully that, if nothing else, all the miles I put in can convince some people of that and be an inspiration for someone. And last one, just got to talk about this. Kathy, you've been here a lot, and I want to help out with your question. So I want to do a food sensitivity test. Do you trust dried blood spot as much as serum testing? Kathy, I hope you're still here. And I saw you had another question, but I'd like to talk more about this one because this might help you personally a bit more. What is your goal for wanting to do the test, Kathy? What are you hoping to achieve by doing that? I can give you some more input based upon that. I wrote a detailed paper on food allergy testing, and I had a recent conversation with many colleagues about this as well. And it's a fascinating thing. There are tons of people that have gone on diets based upon food allergy tests, and they've gotten better in various ways from that. They've gotten better skin, better energy, better mental function. They've lost weight. So there's that. Now, when we look at the medical literature on IgG levels and what they mean, there's as much data saying that your IgG levels show what you do tolerate. There's actually more data saying that than there is that it means it's what you don't tolerate. So it may measure immunotolerance. So and the other problem is that 95+% of these tests are not reproducible, meaning that if you did the test twice, you'd get different results. I mean, like on the same day, you get different results on the same sample even. So how could someone do a test if the data is not valid and get better from that? Well, there's actually a lot of ways. If someone does that diet, maybe they end up eating a lot less processed food than they used to. Maybe they lowered their food intake and dropped some pounds. Maybe they added more variety to their diet. Maybe they added in more produce. Maybe they're eating more mindfully. Those are all, any one of those is powerful. Any one of those could do a lot. Together, they could do quite a bit. Now, there are a few studies showing that IgG-based tests may help people who are symptomatic with inflammatory bowel disease. Now, this data is hit or miss, but some that have ulcerative colitis or Crohn's may have a lower level of symptoms if they follow an IgG-based test. I would still throw the same question. Are they on less processed food? Are they, all these things could still be relevant factors. So the science is not clear that IgG allergens are things that are harming you. So Kathy, there are many that will say things like, if you avoid those foods, your body will have less inflammation. It will heal your thyroid. Well, that's been studied. That has not panned out. So as far as general health purposes go, I don't see evidence that an IgG-based diet would help you. An unprocessed diet is going to be good for you for sure. And you may well be doing that already. I wouldn't be surprised. And all those other factors I mentioned are also powerful. But the IgG part is probably not valuable data for just that side of it. So the US biotech with dried blood spot, that's one of the few labs that does seem to be reproducible, meaning that if you did the test twice, you'd probably get the same results. So that's probably accurate. And yes, you might lower some chronic digestive symptoms based upon that. But I would just push back. And if you're already on avoiding processed foods, are you already eating pretty mindfully? Have you already got a pretty good amount of variety in your diets? Have you thought these things through pretty thoroughly? If you've maxed all those things out and you have some symptoms from Crohn's or from ulcerative colitis, it might be worth doing exactly that. But if that's not your goal, or if you haven't maxed those other steps out, and here's the thing, changing one's diet is not harmless. And there's a dark side to this that we often don't hear about. I see many people that will do a test and they will see this long list of foods that they're reactive to, and they diligently cut them out. And the problem is they've now lost a lot of the variety in their diet. They've lost a source of many nutrients. They may have lost many categories of fibers in their diet. And what happens too is your gut, there certainly are ways that there are some foods that some people will never tolerate. That totally happens, of course. But a big function of what we tolerate and don't tolerate is a function of what we do and don't eat. And so the more things we cut out, the fewer things we tolerate. And so many people, and listeners, please, let me know if this sounds like you. I've been down this road. Many people, for well-intentioned reasons, cut out more and more things from their diet. And what can happen is you can really get less tolerant of food. Maybe the first few things you cut out, maybe they weren't as compelling. Maybe it was based upon a random test or maybe some vague symptoms that seemed like they were related. But the more things you cut out, the less resilient your intestinal tract becomes and the fewer things you can tolerate. I've been in horrible states of health myself as a young man from that before. And I've seen other people in the most dire situations as a doctor. There's one woman, I'm not making this up, she was consuming, her whole diet was hippopotamus meat. You can actually buy that. It's not cheap, but she had kind of worked through every other food you can imagine. So yeah, there's a point where the more foods you cut out, the fewer foods you can tolerate. And yeah, we have this idea sometimes that the healthier we are, the fewer foods we eat, like a matter of pride. I don't think that's the case. I really want to push back on that. I think that's the exact opposite. If someone needs to cut out foods, that can be real, and I feel for you. But it's not a virtue. It's not helpful. It's not going to improve upon your health for other reasons. And I think in many cases, reversing that, kind of like adding an exercise, reversing it may be difficult, but it may be the best step. It may be exactly what your body needs. So if you're someone that's just had a lot of vague things that you don't do well with, see if we're talking about like a life or death peanut reaction, that's not what I'm talking about, okay? So not that, right? But anything other than that, you might even try adding in tiny amounts and just gradually testing that, gradually expanding that, adding that over time. And the other pitfall, so we can have real physiologic changes to our gut. We can just lose our ability to make certain enzymes. We can make less stomach acid. So those things can happen in a completely organic, measurable sense. Now, the other thing is psychological. if any of us are told that a certain thing is dangerous for us, and we're given a very compelling reason why it's dangerous, and we hear others say how they were better off by avoiding it, we take that to heart. We all believe what we hear when it makes sense. We can't not buy into these things in some way. And when we do, we then get real symptoms. We don't make them up. They're not in our head. We get actual symptoms. So if we expect something to be harmful for us, that by itself can actually make that thing harmful for us. If we are told that certain things are going to be a gut bomb, they will be a gut bomb. Now, the odd thing is, in a lot of circumstances, they've done studies on these types of reactions. So, for example, someone just mentioned about gluten. So they've done studies on non-celiac gluten sensitivity. And there are those people that don't have celiac, but they definitely have gluten intolerance, right? Now, when they're in a controlled setting and when they're given foods, when they don't know if they're getting gluten or not, for many people, it doesn't fit anymore. But about 1% of them, it does. But 97 to 98% of people that have gluten intolerance, when they're given a blinded diet and they don't know if they're eating gluten or not, they don't have clear symptoms that correlate with gluten if it's in a controlled setting. So that's what can happen. And yeah, a healthy diet is not a limited diet. That was a bit of a rant. Thank you for the encouragement. Felicia, again, I was pretty much preaching there, but yeah, eat a big range of healthy food. Don't be afraid of food. If there's things that wreck you, yeah, you got to honor that. But ask yourself, has this always wrecked me? Or did this start to wreck me after I read somewhere that it would wreck me? Because that's different. That's not the same thing. And yeah, just take that into account. And to be afraid of food unnecessarily, the stuff that we need for sustenance to survive, I think that's a horrible situation to put someone in, to be fearful of the very thing we need for nourishment. I think that's awful. So, and I say that because I've been on both sides of this thing, but there's totally a valid place for improving one's diet, eating healthier food, less processed food, good amounts of food. But there's a point at where being fearful, if there's not a strong reason for it, is way more harm than benefit. So yeah. Histamine hangover, you just came on. We were having a big long rant about foods and reactive foods and foods being really reactive or not. So yeah. All right, good to see you guys. Happy to be with you today and back next week. A quick reminder, just something I let a little cat out of the bag, partially I guess, that a whole lot of content coming out starting in November about nutraceuticals and thyroid function. I did a massive amount of work for the last book and had tons of data that didn't fit in the book. So I'm going to release a lot of free training for you guys, and I'm jazzed about that. So stay tuned, working on it as we speak, and I'll see you very soon. Happy Monday. Bye-bye.